All right, good evening and a warm welcome to all of you. We just have 1 minute to go. So we have everybody. I would just like to acknowledge our presence of our moderators. Do we have Dr. Shelly Arora with us? Yes.
Yes,
Oh,
good evening.
good evening,
Yes,
Dr. Shelly. A warm welcome to you.
thank you.
Do we also have Dr. Nirmal Yadav with us?
Everyone.
Yeah. Dr. Nirmal is also here. So, with your kind permission, we'll start with this session. Ladies and gentlemen, namaste and a warm welcome to all of you to LMHI 2021, the global colloquium. I would like to introduce our moderators. We have Dr. Shelly Arora with us, and our moderator, Dr. Nirmal Yadav, is there with us. Our session coordinators, we have Radhika Kataria and Ritika Nagpal. And I welcome all the delegates. I would now hand over the virtual dais to our moderators, and they would invite the chairpersons, followed with the first speaker. Over to you, moderators. The virtual dais is yours. Thank you.
Good evening. Thank you, Mr. Hime. My greetings to one and all. I welcome you all to this session of the LMHI Global Colloquium 2021. I'm Dr. Shelley and I will be moderating this session with Dr. Nirmal. Now, the theme of this session is case reports, observational, pragmatic, and randomized control trials. In the first part of this session, we would be discussing about the case cohort studies of children and psychiatric diseases. And in the next part, we will be discussing about the case cohort studies of skin diseases. Now let us start with this enlightening session under the guidance of our esteemed chairpersons, Dr. Annu Kapoor, Professor Dr. Annu Kapoor. She is the principal of Nehru Homeopathic Medical College and Hospital. Welcome, ma'am, to the session.
Well,
No.
good evening.
And we have as a chairperson Dr. Sabel Spino, who is a pediatrician from Turkey. He has graduated from Marmara University, Faculty of Medicine, Department of English in 1994. And he continues to work in her own practice with the mission of providing full healing to the patients by using the methods of homeopathy. Now, without taking any further time, I would, with the permission of the chairpersons, shall I invite the first presenter, ma'am?
Yeah. Yes, please.
Okay, our first presenter is Dr. Sujata Gora. She is from Dr. M.L. Dhavle Memorial Trust, Palghar, Maharashtra, and she would be presenting her observational study on the community-based healthcare intervention for mitigation of malnutrition in children aged 6 months to 5 years through homeopathy as a therapeutic mode. Welcome, ma'am. Dr. Sujata Gore, you can start your presentation, please.
Thank you very much. At the outset, I would like to thank the LMHI for giving me this opportunity to present my experience. I am sharing my slide show. Is it visible, madam? Hello?
Yes, ma'am. Yes, it's visible.
Yeah.
You can make it full screen, ma'am.
Yes, I will do that.
Yeah.
Yeah. So as the topic has been already introduced, I will not introduce it myself further, but we have been working in this field of malnutrition for quite some time now. And so I would like to first give a plan of session for my presentation. I will first begin with the background of the work of the trust. Then I will give a primary overview of the malnutrition. Then I will present our findings about the pilot study, the insights that we got, and the further plans, and how we upscaled and what was the outcome of the same. And I would like to share two illustrative cases. After that, I will be able to share the conclusions and the future plans. So with this, I will begin with our trust, Dr. M.L. Memorial Trust. We have been working in for last 25 years in the 25 villages of the tribal dominant parts of Vikramgarh block, Palghar district of Maharashtra. And we have been working with mother and child sector as that's the weak section of the community. And our finding has been that the children here are definitely lagging behind in nutrition and growth. So we had also an idea about the prevalent state of nutrition of children in India, Maharashtra. the survey suggested that all the three factors of stunting, wasting, and being underweight has been going on for quite many years. And the government schemes have been supplying the food in various forms under integrated child development schemes for the last 20 years. But we actually don't see a proportionate difference in the health and the nutrition of the children. So this posed the question as to whether really the malnutrition is caused entirely due to lack of food security, or are there any multiple causes for the same. So for understanding this, we wanted to understand what's nutrition. So according to the Nelson's pediatric book textbook, we see that it is influenced by biological, psychological, and social factors, and this affects various aspects of child development, physical as well as intellectual growth. So the environment here is more or less same for all the children. But we see that there are 40% children who are malnourished and 60% children who are normal. So the factors which could be contributing to the nutrition and also as a result of that to malnutrition must be into the sphere of the child's internal factors, biological as well as psychological. This was a postulation, and then we thought that homeopathy can handle the state of individual susceptibility, and these factors, biological as well as psychological, they contribute to the individual susceptibility. So this could give us a solution to the problem of malnutrition. So with this, the objectives of the project were defined. So we wanted to explore the exact etiological factors and also the role of the homeopathic similimum in improving the malnutrition. Apart from that, we wanted to determine what are the other strategies that are needed for achieving this and how we can make this into a sustainable model of intervention to mitigate this problem of malnutrition. So the pilot study began in 1516 and we had surveyed 1080 children from 18 childcare centers in our area. Out of that, we selected 95 children who were under the zone of moderate malnutrition. Now, malnutrition, as we all know, is a spectrum of problems ranging from mild, moderate to severe. And moderate malnourished children are very trickily balanced. If they get worse, then they can get into the severe zone, and which is known to have morbidity and mortality for the children. So we wanted to intervene here and not allow them to get to worsen. So out of 95 children, 84 completed the treatment, and the outcome is there in front of you. There was a remarkable improvement in the weight and height and also the load of infection. So more than 65% of the children improved. So considering that the observations like appetite, activity, mood, everything improved, as well as the load of infection and infestations improved, and the measurements also improved. So that indicated that the homeopathy had definite role to play. It also told us that the factors which are responsible are not only the food insecurity but also the environmental factors which are external causes which maintain the problem, but more importantly the internal factors which are responsible for digestion, assimilation of the child and the infection load. Apart from that, the fundamental causes where the reproductive population is also malnourished. So the parents are malnourished basically. So these are all the three types of causes which can give rise to and contribute a lot way in malnutrition. So these were our further strategies. We wanted to upscale this to confirm these findings. We had to educate and orient the community for better feeding practices. We had to also integrate the feeding plans by the government into with our homeopathic interventions. And we had to train the community workers and doctors especially for implementing this. So it was a holistic intervention plan with preventive, promotive, and curative strategies in place, a proper Hahnemann concept. With this, when we upscaled, we screened 4,000 children, out of which 1,600 were found malnourished, and out of the 1,000 that fell in the group, we selected 600 from them who were moderately malnourished. The data collection was done with from the parents and the Anganwadi workers, that is the child care center workers. This was done primarily by our field workers on a special screening form in the local language, and they also could examine the weight, height, and mid-arm circumference. The physicians then took over and took the further data on a special case paper. Then they evaluated them clinically and also homeopathically for finding out the characteristic symptomatology of each child so that they could arrive at the minimum. And simultaneously, we had to remember that the parents were actually not aware of malnutrition. So we had to go on interacting with them and orienting them about this problem of malnutrition. So as a strategy for problem solving, we had this curative strategy definitely where we had found the individualized minimum and we administered that in the relevant potency and repetition. Apart from that, the preventive strategies, apart from the feeding practices, we also improve their hygienic practices so that they don't fall sick with the recurrent infections. The promotive practices, we had gone on orienting the community, family, individuals, so that it becomes a holistic cure pattern and it brings about change in the individual and the environmental susceptibility so that it becomes a sustainable effort. For this, we had multi-layered monitoring where our community workers as well as physicians used to monitor them regularly and a regular orientation about homeopathic medicines and their utility in the management of malnutrition also went on. Now we see the outcome of these children. 549 children could complete the treatment from 6 months to 3 years. It was a variable length of period of time. We see that weight percentile improved in 50%, height percentile improved in 78%, and recurrent infection load also improved in 72%. So thus we see that there is a lot of improvement in the child. Also because the feeding practices improved to some extent and the awareness about the illness as well as the homeopathy also improved and the health seeking behavior of the community improved. So which shows us that the improvement occurred at the individual susceptibility level as well as the community susceptibility level. As far as the remedial part is concerned, we could see that there were some group of symptoms which were common in this community, which gave us a group of remedies, which ranged from polycrest like natrum silica, calcarea, mercury, lipo, to children remedies like chamomilla, sina, canicula. And as an antimiasmatic force, we could use tuberculum with a very good effect seen on the child's growth. These are the two cases that I am going to talk about. And this is the first child who was born with 2.5 kg weight. And due to the recurrent infections, she was only 5 kg when she should have been 8.2 kg at 9 months of age. This was 51 percentile of growth, which indicates a severe malnutrition. So this child was taken up in the project and she was given the after taking the data, we gave her the minimum and at 2 years of age, she should reach to 11.5. So this is the growth chart that you are able to see. This was maintained by our workers and we see a definite change from the red zone to the green zone of nutrition, which indicates a definite improvement. So the conditions didn't improve, the external conditions, but the force that we used could change the individual susceptibility and because of it we are able to see this change. The second case is of a baby boy who was already underweight at the birth and then due to recurrent infections, the child could be only 7.1 kg at 13 months of age when he should have been 10. So he was 71 percentile and this was a case of mild malnutrition. Again, the same thing happened that after the intervention, we could see that there was a definite change in the appetite and infection. And as a result, the child could reach to the maximum growth potential here. The child has reached to 100 percentile and even as per the WHO guidelines also, he is crossing 85th percentile. So this is a immense improvement in the child even though the external environmental factors remain the same. So to conclude, what we can conclude from these efforts is that it's a multifactorial problem and it needs a multifaceted intervention. So correction at one level will not improve the nutritional state of the child and it will never sustain. So since genetic, biological and psychological factors contribute to this etiology, individualized homeopathic treatment to tackle the susceptibility definitely will be helpful. Homeopathic interventions, apart from bringing about the change in the individual susceptibility, it brings about an overall change in the health of the child. Education and orientation of the community helps in improving the community susceptibility and community participation, which goes a long way in sustaining this effort. And improvement at all these levels will definitely become covering the preventive, promotive, curative strategies. So it's a perfect homeopathic phenomenon cure. So to conclude about the training modules or if we want to intervene at other places, we need to have training in place. We need to have robust data recording in place. We need to have a complete knowledge of the differential indications of the remedies that can be indicated. We need to have potency, repetition, and use of how to use anti-miasmatic forces. That all that we need to train our physicians, and we need to keep a proper monitoring of the follow-up on special follow-up sheets. If we are able to implement all these things, then I'm sure that community-based healthcare initiative definitely can mitigate this problem of malnutrition through homeopathy as a therapeutic mode, and it definitely can be scalable at other areas as well. So with this, I will say our future plans. We would like to have a control study so that we are able to strengthen the findings further. This was basically an observational study, so we will like to have a control study and expand to the blocks and district level so that homeopathy should reach all child care centers in the country for the malnutrition to come down. With this, I will like to thank my DIGA organizers, my faculty of MND Trust, MLDT Community Health Center, the complete field workers team, and of course the tribal community, which gave me this opportunity to experience and share this with all of you. Thank you very much. So I hope I have been able to present it in the time that was given to me.
Yes, thank you, Dr. Sujata. Such a nice presentation. And actually, I agree with Dr. Sujata. Malnutrition is such an important problem in the whole of India, not only in Maharashtra, but the whole of India because of the socio-economic status of the country. And I think more of such studies should be conducted in other parts of the country as well. Now, I would request Dr. Anu, the chairperson, if she has any question for Dr. Sujata.
Yes, Dr. Sujat, this was a very good presentation, a very good study. But I just want to ask one question that while you were doing this study, were you giving some counseling to the parents as well regarding malnutrition, what to give to the children and all?
Yeah. So we were giving this counseling to the parents. We were explaining how to make different recipes out of the ICDS food that you get, usually the ration that you get, and also the importance of feeding their children properly from time to time. The entire area is having a migration problem also. So when they are not there in the village, how they should handle their children's nutrition, so that the nutrition doesn't suffer just because they are away from the area that they live. So all this was going on simultaneously. That is why we were able to see that the behavior change also slowly, very gradually it is taking place. It will take a long time for the community's behavior to change, but our efforts are always there and we have been doing that.
But what about the low socio-economic people? Like, how could they meet the diet potentials and all? Could you suggest them some cheaper things like jaggery and other
Okay,
things?
very good question, madam. Actually, we had done a lot of cultivational, motivation also for them, where we ask them to grow their local, this ragi, which is very good for health, and it has got, eradicated from the area, I would say. So we have been promoting this ragi cultivation again, and we are also asking them to cultivate vegetables in their own, backyard, so that their needs get fulfilled and their children get complete this thing. And even the moringa leaves, which is a very good source of nutrition, proteins as well as minerals, and which is very much available in the area. Apart from that, even the curry leaves, which is also very prominently available. So we are being promoting all these locally available produces so that the nutrition doesn't get hampered because exotic things are not available. So I hope that with this, continued education and orientation of the community,
It is very
change
necessary.
will take place
Very
in
good.
the time to come.
Very good.
Yeah.
And one more thing, were you ever handling the antenatal females?
Yes. Yes.
At that level, were you scrutinizing them, screening them for anemias and other diseases, malnutrition?
Yes.
Because if the mother is anemic, the baby is bound to be anemic. So could you
Yes.
combat that aim?
We are also working not even antenatal. We are working from adolescence. We are tracking girls for anemia. We are handling that, and antenatal checkup is an integral part of our program. And in fact, the infant and young child feeding practices, which covers the 1,000 days of the child or the infant. It starts from the antenatal age. So the 9 months during pregnancy and post-delivery for almost 2 years, if we are able to take care of the child from all these angles, take care of the mother's nutrition, take care of the feeding, the breastfeeding practices properly. I'm sure that along with homeopathic medicines, if all these things are done properly, the malnutrition eradication is not a
Yes. And I also suggest that if you take your study from, you start your study from infancy, that
yeah,
would be very good, because you would try to attack malnutrition right from the beginning,
right.
promote breastfeeding and all,
Yeah,
educate your group better. Huh?
yeah.
Yeah, very good. Thank you. Thank you, Shelly.
Yes. Thank you so much, ma'am. Thank you. Thank you, Dr. Sujata. In fact, we need to address this situation right from the beginning as a holistic approach. Thank you, Dr. Sujata. And now we have our next speaker who is going to talk about another important problem of childhood. We have with us Dr. Praful M. Barwalia, who is the founder chairman of Spandon Holistic Institute of Applied Homeopathy in Mumbai, India. And he would be presenting the observational study on effectiveness of homeopathic treatment in sensory processing disorders in autism, ADHD, and learning disability. Welcome, sir. You can kindly
Thank you.
start your presentation.
Thank you. Thank you, madam. Respected moderators, respected Dr. Sharma, respected chairperson, it gives me immense pleasure to share my experiences related to sensory processing disorders with this august gathering. Now, as you rightly said, that sensory processing disorder becomes most important. Sensory processing is an integral part of neurodevelopment of the child. As German philosopher Immanuel Kant has mentioned, all our knowledges, begin with the senses, proceeds then to understanding and ends with the reason. There is nothing higher than the reason. So this itself explains that we start receiving things from our senses, and how we process it determines how we are going to act, how we are going to grow. And the first 24 months are quite crucial, wherein synapses are evolving. And at that time, if these pathways are impaired, obviously it will have far-reaching implication. Sensory processing disorder is a condition in which sensory organs, sensory signals received by the CNS do not become organized into an appropriate response. As a result, you are not in a position to work out the entire loop of sensory integration. So sensory input, motor output, as well as cognitive aspects all suffer. If I give you an analogy, imagine driving a car that isn't working well. When you step on the gas, the car sometimes lurches forward and sometimes doesn't respond. When you blow the horn, it sounds blaring. The brake sometimes slow the car, but not always. The blinkers work occasionally, the steering is erratic, and the speedometer is inaccurate. You are engaged in a constant struggle to keep the car on the road, and it is difficult to concentrate on anything else. This is exactly is the plight of a child who suffers from sensory impairment. Like every time you tried to write with your pencil, it broke because you pushed too hard. The different smells in the room made you utterly nauseous. The humming of the light sounded louder than my voice. You couldn't focus your eyes on me because everything and everyone in the room catches your attention and your eyes just go there instead. So, the person who suffers from this impairment at various levels, auditory, visual, proprioceptive, tactile, vestibular. It will have impact at number of aspects. Now, this disorder definitely has great impact in autism, in ADHD, as well as in learning disability. And to some extent, we will see it will be associated with number of other neurodevelopmental disorders or developmental coordination disorders or child psychiatric disorders. Because after all, sensory integration is an integral part. So we are working at Spandan. I established Spandan in 98 with the view to work with the children with developmental disability, keeping homeopathy as a central therapeutic modality. So we have studied 234 cases of sensory processing disorders from 2001 to 2011. This includes 60 cases of autism disorder registered, studied, and managed at Spandan under auspices of Ayush-funded extramural research project, and 32 cases of autism where impact of homeopathy was studied on cases receiving occupational therapy. Now, in fact, this got initiated by our therapist friends, even from other institutes as well as special educators. They approached us that this is really a disturbing area, and when child suffers intensely, the behavior is so bad that we are not in a position to work out our therapy. Can you help us? And so that way we could have data wherein before intervention, what was happening to the child, and after intervention, what happened. And in fact, the whole thing was initiated with the help of occupational therapist. So it had greater authenticity. These children were studied for 6 months when they were receiving occupational therapy. Then homeopathic medicines were administered while OT continued. Differential impact was studied for another 1.5 years. Apart from the regular stages of screening and all, the most important tools for autism, childhood autism disorder through DSM-4 and ICD-10 diagnostic criteria. Of course, DSM-5 now, it was 4 at that time. Childhood autism rating scale, internationally recognized ATEC, SQ, the cognitive ability through VSMS. Only those children who are quite high functioning, there we could carry out IQ through Binet Kamath or Wechsler. But many children who suffer from associated cognitive impairment or who have tremendous behavioral issues, there those tests could not be applicable. So VSMS was something which intensely helped. And autistic hyperactivity score, we had evolved over a period of time to judge the hyperactivity. EEG, BERA, serum serotonin, genetic evaluation through karyotype, audiogram, and advanced evaluation through MRI in few cases where neurologists suggested that. Now, autism treatment evaluation checklist, which is a very important tool evolved by Autism Research Institute USA, that helps a lot, and remedy response comprehension form for homeopathic processing. Now, autism treatment evaluation checklist gives us 4 important components: communication, socialization, sensory impairment, and health and behavior. These are the 4 aspects of autism which analytically the ATC scale gives, and this we reflected in appreciating the hyperactivity, which we classified from our perspective as kinetic, stereotype, regressive. We'll see that through one illustrative case of 9-year-old child who came to us, who had apparently normal milestone, used to call mama, dada, used to repeat rhymes, but regressed at the age of 1.6. Poor eye contact, jumping, self-destructive behavior. Husband was alcoholic. She felt he does not like her. During pregnancy, she felt extremely depressed, low, rejected, and dejected, and always felt uncared for. Child suffered from chicken pox, father alcoholic, maternal grandfather alcoholism, maternal grandmother diabetes mellitus. So you need to take into account the miasmatic dimension. You have to find out whether there is consanguinity in marriage, which could have a genetic dimension. The hyperactivity, try to identify peculiarity, marked violence, beating self-destructive behavior, striking head, self-injurious behavior was quite prominent in this child with pronounced fear of noise, tremendous auditory sensory issues which were available. What was peculiar was a monomanic activity. He loved drawing sketches, can draw just from his memory, calms down if he gets to write or draw, almost goes into drawing frenzy. That is what the parents described, and he would beautifully give the replica. To that extent, he will draw the sketches. So once even police had taken his help to identify one culprit. So this was the island of ability in this child. CARS, mild autism 32, 73 ATEC, 60 to 65, mild retardation in social functioning, AHS 52. BERA, EEG were normal. Now, restless behavior, mild retardation, recurrent infection, peculiarities goes into a frenzy for abstract drawing and sketches, very good in fine motor skills, and we have seen the regression. Now, with the help of this, we evolved the entire totality where we are seeing the child has autism, mild retardation, recurrent infection. But what is peculiar is this behavior, self-injurious, tearing things, destruction, and the noise. And when we repertorized, we found belladonna, stramonium, hyoscyamus, and lysine coming up prominently, taking into account the self-destructive behavior, restlessness, fear, and if you correlate with mother's state of rejection, the forsaken feeling, the lysine came up, which was given 201 potency, and we could see in a period of around 6 months a significant relief. With the child had all the scores were done, wherein we could see the CARS from 32 to came down 31 in a year's time, while ATEC from 73 to 62, and AHS from 52 to 19. So significant response in behavioral issues, and ATEC also we could see in a year's time showed marked improvement. All other features as well as the sensitivity. Much later we gave carcinosin when we did a study that was almost after a year, and that completed the cure. We need to study our materia medica, which shows the peculiar syndrome of the sensory issues. This is the only therapeutic line which has pronounced sensory aspect recorded in textbook. So here we are in a position to work at that level. Now this is a well-documented case. I will not go into the detail of the case. You can go through in the journal, and we could also verify a number of clinical symptoms. When we study all these cases and where the sensory component is so predominant, phosphorus, Naxomica in China came up more frequently when it is associated with marked hyperactivity. Stramonium, belladonna, tarantula, sina, and aurum came up. And when these features are associated with regressive aspect like involuntary urine stool, hyoscyamus bufo, zincum met, and Barita carp, they come up. Of course, carcinosin, medorinum, natrum and tuberculinum came up whenever there is a strong dispositional similarity in those cases. We need to go definitely at much deeper level and try to identify what are the other layers at a much dispositional level, at a core level. And quite often you will discover that those layers will get manifested over a period of time. Like in this case of lysine. With lysine, so much of improvement, all intense, hyperactive, as well as sensory issues reduced, the scores reduced, and then we could see certain cravings came up, desire for traveling came up, and carcinosin came up glaringly. So that is how you see the sequence of remedies which will come up in all these cases. When we studied our autism research cases, in the self-control period, 6 months before intervention, we had seen when we started the autism treatment evaluation checklist, mean score was 72, which had gone up to 79. As I mentioned to you, it was therapist and educator who were saying that very bad behavioral and sensory issues, can you have some remedy? And since the cases were deteriorating, then we intervened. We carried out ATEC every 3 months. And then at the end of a year, we could see from 79, it came down to 64. So you could see a distinct change of 19.72%. Earlier, cases were deteriorating. There was minus 9.88. So now it has definitely gone up, and it is 19.72% change which has come up. And the component, and if you study the component, the behavior 29 and sensory 18.82, which comes up much more. Communication improves, but improves little later and slowly, while sensory and behavior improves faster. And that is what we see, that in the first quarter, 34% changes take place in the autistic parameters, and in second quarter, 26. Now, the researchers have mentioned earlier that whenever there is new therapeutic modalities introduced in handling of sensory processing disorder like autism, and if there is distinct change in the first 3 months after that modality, then definitely credit goes to that modality. And our results were consistent to that. We could see distinct changes even in the degree of autism. You can very well see the severity, how it has come down, and see the p-value. Even at cognitive level, we could see the changes which have taken place. Children who had, when we started, 24 mild MR, now it is 30, 27 moderate MR, number of cases, moderate autism, now it is 11, and you had severe 9, so now it is 6. So gradually you could see, even we could also identify a distinct change, that 9 cases of autism came down in non-autistic zone after homeopathic intervention. 8.33% of cases were status quo, 26.67 had mild improvement, while 35% had moderate, while marked improvement was 26.67. So you can see significant change in more than 60% of cases which was observed, and a definite improvement in 88% of cases at the end of a year which was observed. 6 months before control period, when ATC was around 70.67 and went up to 73. I am referring to another group of those cases, 32 cases, which occupational therapist had initiated. There in 18 months, when we just examined the sensory component, sensory index, the changes were 46.41% at the end of 18 months. So you can see that in the sensory issues, you can bring about marvelous changes, and that too in 1.5 period of time. Homeopathic medicines have profound impact on sensory issues and bring about its correction fast. Homeopathy is the only science which can modify sensory processing impairment, reduction of autistic, ADHD, and LD features, and thus rehabilitation in mainstream society for the child can be achieved through organon-based homeopathic approach. Out of 60 autistic in 1 year, 9 became non-autistic. Today, at the end of 18 years of observation, we have seen number of children who have even cleared SSC 12th and graduation, who are labeled with this kind of serious sensory impairment disorders. So friends, I am really thankful to LMHI for giving this opportunity. My sincere thanks to all my colleagues. My thanks to Dr. Nrupen, who has been undertaking research in sensory processing, doing his PhD under me, as well as I am also thankful to Dr. Jawar Shah and his OMPAT team for always helping academicians to enhance their presentation. Thank you all.
Thank you, sir. A very well presented study, sir. I think we are running short of time. I think you have exceeded the time limit for the question and answers also. So if the chair permits, can we go on to the next speaker directly? We can save the questions for Dr. Praful for the discussion at the end.
Yes, Shelley, yes, we can.
Okay, ma'am. Thank you, sir. We can discuss further whatever questions we have with you at the end of the session. And now I request or I invite Dr. S. Karunakaran Murthy from Kottayam, India. He is the research officer at National Homeopathic Research Institute in Mental Health. He would be presenting a case series on the homeopathic management of conduct disorders. Over to you, sir. We can't see your video, sir. Can you please switch on your video?
Yeah. Are my slides are visible?
Yes, sir. Yes, you may start, please.
Thanks for the introduction and greetings of the day to all the panelists and my fellow researchers. Today, I would like to present a case series before you entitled A Homeopathic Management of Conduct Disorder. And I would like to begin by giving you a brief introduction about conduct disorder. Conduct disorder is a psychiatric syndrome occurring in childhood and adolescence and is characterized by pervasive pattern of hostile, aggressive, cruel, deceitful, and destructive behavior. The etiology of conduct disorder involves an interaction of genetic, familial, and social factors. Conduct disorder increases the risk of several public health problems, including violence, weapon use, substance abuse, and dropping out of school. It was found to be more prevalent in boys than in girls. It is most common psychiatric disorder in childhood with a prevalence of around 5% across the world, which is rising. Moreover, up to 60% of adults who developed a mental disorder had conduct disorder or its frequent developmental precursor, oppositional defiant disorder earlier in life. Therefore, it is most important to identify conduct disorder and begin intervention as early as possible. 3 cases of conduct disorder are presented here, which had been treated exclusively with homeopathic medicine without the aid of any supportive therapies. Coming to the patient information, the patient visited the psychiatric outpatient department of our institute with complaints that met the criteria of conduct disorder. There were 3 adolescent boys of age 10, 11, and 17 years. They presented with the symptoms of conduct disorder like anger, hurting tendency, destructiveness, obstinacy, cruelty, fire setting, using weapon, stealing tendency, and craving for alcohol. There is no family history of psychiatric illness in all 3 cases. 2 cases were from low socioeconomic status. In these cases, it was observed that the following psychosocial factors were involved in the development of psychopathology: parental divorce, residing in orphanage, separation from parent, physical abuse, and parental death. Have a look at the clinical finding, that is the mental status examination. When considering the behavior, it was difficult to establish rapport with the case 1 and 2, but not with the case 3. Case 1 was appearing restless and excited. Second patient was hostile and had disregard for the hospital environment. Third patient was appearing anxious. Eye-to-eye contact was maintained by all the 3 cases. Speeches of first and third patients were normal, whereas the second patient had increased volume of tone of speech. The thought content of all 3 were abnormal. First one had thoughts of dead relatives. Second one had thoughts of killing his parents. And third one had thoughts of stealing. First and second patient had irritable mood, while the third one was anxious. Affect was appropriate for the all 3 patients. First 2 cases had no abnormalities in cognition. Third patient had poor attention and concentration. And all the 3 of them had poor relatedness to parents as well as the examiner. While considering the attachment behavior, first one seems to be observed in his own world, and second one was impulsive and overactive, and third one had restrictive behavior. Let us focus into the diagnostic assessment with the presenting complaints like anger, hurting tendency, destructiveness, obstinacy, cruelty, fire setting, using weapon, stealing tendency, and craving for alcohol, present for a period of about 12 months, as well as with the mental status examination. The consultant psychiatrist diagnosed the case as conduct disorder according to the Diagnostic Statistical Manual of Mental Disorder, 5th edition. Then the therapeutic intervention. All the cases were treated by adhering to the homeopathic principles. Individualized homeopathic treatment was given. Moving on to the follow-up. Case 1. He was admitted in the inpatient department for management. There were intermittent violent episodes in the IPD which were managed by stramonium 200 in repeated doses. He was given 3 pills of 40 size globules 4 hourly till the intensity of symptoms reduced. Then he was put on placebo. Stramonium was prescribed based on the presenting symptoms like increased religiosity, cruelty, anger, spitting tendency, and threatening nature. Stramonium seems to be more suitable than the rest of drugs for the alleviation of acute violent outburst. He was discharged after 2 months with marked improvement. He continued regularly monthly follow-ups. Stramonium 200 was prescribed as SOS for episodic anger. The episodes of anger was managed with 12 doses for a period of 6 months, January to June 2019. Thereafter, he was managed without the help of SOS so far. To free him from the disease, he needed prolonged and deep-acting miasmatic remedy. So a dose of carcinosinum 200 was given as intercurrent based on the repertory session. Have a look at the repertory chart for the acute totality based on the symptoms of destructiveness, cruelty, temper tantrum, spitting, face of people, anger, contradiction from, threatening, religious affection, want to read the Bible all the day, religious affection, especially in children, dreams of dead relatives. So stramonium came up first in the repertory chart and it covered most of the symptoms also. So stramonium was selected. Now look into the chronic totality. The causative modality and other prominent characteristics were taken, like irritability, ailment from domination, especially in children, and ailment from neglected being and religious affection in children. So carcinosinum came, so it was prescribed. Now let us look into the second case. The patient was managed in OPD setting with a natramur 200, keeping in view the cause of ailment, hatred, revengeful nature, aggravation from consolation, and other physical general. Natramur was selected. Natramur 200, 3 pills of 40 size globules, 4 hourly was repeated 3 to 4 times, but there was no improvement. So the potency was raised to natramur 1 His complaint started reducing gradually after taking 2 doses of natramur 1 daily for 3 days. After that, patient managed the adverse situation at home without creating much discords. He continued regularly monthly follow-ups. Natramur 1 was prescribed as SOS. For the next 6 months, he had to take it twice for his uncontrollable anger. Thereafter, there was no episode of anger till now. The repertory chart shows that natramur is covering all the prominent symptoms of the patient, like ailment from discard, parents between one, and animals, love for animals, children in, consolation, aggravation, despair, fear, insect of, hatred, revengefulness, haughty, anger with malicious, precocity of children, rage, constipation in children, desire for ice cold drinks. So natramur was selected. Then moving on to the case 3. He was admitted in the IPD in September 2018 for management, keeping in view the tendency to steal, yielding disposition, sensitiveness, dreams of ghosts, and other physical general. Pulsatilla was selected. When intensity of symptoms like anger, provocative behavior, and destructiveness reduced after 1 month, he got discharged. Pulsatilla 200 has been given every month for a period of 8 months. Stealing tendency persisted, but the frequency of episode got reduced. So he was admitted again on July 2019 and Pulsatilla 1 was prescribed. He got discharged after a month. Pulsatilla 1 was prescribed as SOS for the 2 more months. He took the SOS. Thereafter, stealing tendency got markedly reduced. Patient is under placebo for the last 8 months.
Excuse me, sir.
Yeah, right.
So we're running short of time. A little. Can you please wind up in another 1 minute, please?
Yeah, right. And totally the outcome was measured with the conduct disorder diagnostics tool and conduct disorder rating scale parents versions. And finally, I would like to say that the timely intervention has prevented the deterioration into the chronic psychiatric ailments, but the cases need long-term follow-up for complete recovery. Thank you for all patient listening.
Thank you so much, sir. Sorry for interrupting you in between.
Yeah, it's okay.
But we just have to adhere to the timings. And it was such an enlightening case report. I think this is a very relevant topic in today's time about the children and the psychiatric diseases. And Dr. Anu, the chairperson, do we have a question here?
Yes, just one question. Dr. Murthy, what have you been doing of the acute episodes in children? How were you managing them?
Ma'am, during acute episode, we used to see the behavior of the children, the way of reacting the emotions like affect and moods, like how they are affect, how they are moved, what is the thought content of the people, how they are react to us, to the clinician as well as the parents.
But
That's the main clinical presentation.
were you still sticking to homeopathy itself, or you were taking some specialist opinions?
No, ma'am. This in our institute, consultant psychiatrist is there. He used to help us for the diagnosis of the cases.
Yeah.
And homeopathy we are managing.
Medicines, no homeopathic, no allopathic medicines at all.
No, ma'am. There is
You
no.
were purely managing all the acute episodes also with homeopathy.
Yeah, most of the cases. In case if the patient is very severe, it could not able to manage the cases. He used to help us.
Okay.
We are having, it's a 100-bedded hospital, so we are having cabin also. And in case if the patient is manic over severe episode, so
Maniac
we
or
chemical restraint we used to do.
Okay. Okay. Thank you, sir.
And these 3 cases are only managed with homeopathic management without any other medication or therapies.
Okay. Okay. Very good. Very good. Very good.
Okay,
job.
ma'am.
Great.
Okay. Thank you.
Thank you, sir. Thank you, ma'am. I think we have a lot more questions, which we will save for the end for the discussion. For now, I would request our next presenter, Dr. Kuzmina Irina. She is from Moscow, Russia, and she is going to present a case report on the concept of prima causa morbi from the point of view of the chronic miasms of Hahnemann on the example of a case of severe malabsorption syndrome of a child. Dr. Kuzmina, please.
Thank you very much. Thank you.
Welcome.
Hello to everybody. I try to make my presentation.
Yes, now it's visible.
It's visible. Yeah, thank you very much.
Yes, yeah.
Thank you. Let me present you the clinical case. Of 13th of February 19, a patient asked for help about her 6-year-old daughter. The girl was already about 2 weeks on medical treatment in a children's hospital with a diagnosis protein energy deficiency of severe degree, cachexia, hypertrophy of the
One
third
second.
degree.
Excuse me, ma'am. Ma'am, please start the presentation.
Excuse me. This.
Yes, yes.
Yes, I forgot.
No, still you haven't started the presentation.
Yes,
Full screen?
yes, this is
Okay,
a
or you
second.
can change the slides
Yes.
as you wish.
You can see I changed the.
Yes, okay,
slide.
okay,
Yes,
fine.
okay. Cachexia, hypertrophy of the third degree, candidus of the oral mucosa, chronic purulent otitis on the right, acute purulent otitis media on the left, chronic two-sided hearing loss. A subclavian catheter is installed for parenteral nutrition. Infusion correcting therapy was performed to glucose salt solution, medicine of potassium and calcium, swelling of the legs and feet, daily foamy diarrhea in blood test ALT 250. Anamnesis morbid. Since the beginning of December 2017, she has been receiving homeopathic treatment from the other homeopathic doctor. She took Hininum arsenicosum 12 once a day for 3 weeks. According to her mother's words, after this remedy, her mood became worse and her weight began to drop progressively. By the end of December 2017, she had lost a lot of weight. Since January 21st, she had been receiving Aprotanum 12. In February, she received Silicea 200 once, but her condition gradually worsened. Dehydration, cachexia, and general weakness increased. The patient was urgently hospitalized. At this stage, my colleague asked for my help in managing the patient. The girl received the BCG vaccine in the hospital when she was born. In 1 year, the child suffered pneumococcal meningitis, after which the girl had pyelonephritis. From 1 year to 2.5 years, she took a lot of antibiotic, almost every month. At 2.5 years, a bilateral sensory hearing loss of 4th degrees developed. At 3 years and 10 months, she underwent cochlear implantation. At 4 years old, she suffered from purulent otitis on the left side, received antibiotics, and still had periodical discharge from the ears. Because of bilateral sensory hearing loss, she does not hear the speech addressed to her. From food, prefer macaroni, soup, sweets, like salty food, does not tolerate milk, although she loves it. She is thirsty. The mother is as a second marriage, walks a lot. The girl raised by her grandmother. The girl misses her mother very much. The father has allergic dermatitis and alcoholism. The mother has migraines and psoriasis. The younger brother has allergic dermatitis. The relatives of the parents have various mental illnesses. The girl has lost a lot of weight, especially over the past 2 months. Her weight is 20 kilograms, and she is 6 years. The girl eats slowly, for half a teaspoon, but often hungry and often asked to eat. Her stomach is swollen, constantly liquid stool, watery gray with fetid smell, foamy, with undigested food. The child's mood is bad, doesn't want anything, constantly has frowning face. Everything is wrong and all is wrong. Doesn't want to contact to anybody. Her head sweats in sleep. Weeping frequently, obstinate, starts to play little, demonstrates no interest in life. This is a photo of her stool and the swelling of her legs. The analysis of the case of my colleague. You can see calcare, mercury, silica, arsenic, and others. Let's turn to Dr. James Compton Burnett. I cannot accept the view that the disease is entirely symptomatic because it's not correct. The disease may or may not be limited to a set of symptoms. It's not enough to cover the totality of symptoms. This will only do half the job. In order to cure a disease with remedies, they must be related to a pathological process in a certain way, and it does not matter whether the symptoms reflect this process. John Gary Allen, chronic miasms. In the phenomenon of indigestion, we must look deeper and further that within the limits of gastric functions. Indigestion has under it, like all other impairment functions, an upset vitality. Gastric manifestations are as a secondary as in erysipelas, eczema, of any rash of skin. These disorders of any nature are nothing more than an attempt of nature to eliminate the influence of miasma in the body. This stool of tuberculosis child is gray or grayish in color, and it shows the absence of bile in serious cases of intestinal diseases. After defecation, there is exertion. Tuberculosis child is capricious, irritable, weeping, doesn't want to be touched, even to be looked at. In a tuberculosis patient, we observe a general exhaustion, a loss of strength, a feeling that life leaves him at every bowel movement. The face is pale and earthy. The eyes are sunk with dark circles around them. Rapid exhaustion, prostration, often with intense thirst. So, I made a new analysis of the case. Important historical miasmatic symptoms are taken into the set of symptoms, and you can see on the third place tuberculinemia. The course of treatment. 18 February, she received tuberculinum 201 dose. 22 February reports The child is better, stool is less frequent, sweating remains, appetite is increased. She does not yet add weight. The weight is 20 kilograms. The 5th of March, the weight increased to 14 and a half, but the child is sad, doesn't smile, refuses to play. It's hard to her to let the mother leave the hospital, often cries and often feels offended. I gave her 1 dose of natrium muriaticum 200. 11th of March, the stool are formed, the diet was expanded, the girl began to smile, there was an interest in life. She asked to braid her hair, paint her nails, and to play with her. Weight is 16 kilogram and a little bit more. Repeat prescription, tuberculinum 200. 16th of March, the parents took the girl from the hospital. Mom's report. Appetite is very good. Eats a lot. Began to eat a lot of ice cream. Eats chicken in soup. Eats every 2 hours, but constantly asked to give her to eat. And more often, if I do not give her food, cries. The stool is formed and normal once or twice a day. She began to play a lot, to draw. There is some discharge from the left ear. Recently, a lot of yellow-green content come out for the nose. No prescription. 26th of March. The condition is stable. There are no new symptoms. Bothered by discharge from the ear. Repeat tuberculinum 200 according to Burnett experience. 2nd of April, the mother sent a photo of the child and may report. We have a good news, the appetite is good, the skin is not dry and desquamate, the girl has become thick, leg, arm, body is not longer thin, the stomach is slightly swollen, there are cheeks on her face, sometimes sweats after eating, periodical discharge from the ears, no prescription. The end of the case, 28th of May. The condition is stable and good. There are no complaints about the child's digestion. The mother was advised to bring the child to a doctor's appointment due to chronic hearing loss. The conclusion. The presented case clearly demonstrates the history of long-term suppression of various inflammatory processes, as a result of which the child developed a severe malnutrition condition, which led the body to the stage of cachexia. Despite 2 weeks intensive therapy in the hospital, there was no positive dynamics. Only the use of homeopathic treatment gives the child a chance to quick recovery, and the disturbed balance of vital force was restored. This case also interesting from the point of view of the approach to analyzing the character of miasmatic process and the strategy of choosing the right simile. Here, we see that mechanical repertorization as superficial analysis of the symptoms of the disease led to the wrong choice of homeopathic remedy and the lack of therapeutic effect. Only deep analysis of the case, taking into account the miasmatic history of the patient and her family, helped to list right totality of symptoms and choose the right homeopathic remedy, which act on the true prima causa morbi and led to light and fast recovery of the patient. Thus, ignoring the great discovery of Samuel Hahnemann, his theory of chronic miasma can lead to the fact that it will forever remains on the margins of homeopathic practice. And then, according to John Henry Allen and Compton Burnett, our daily practice, without implying anything, will engage in scientific palliative treatment instead of deep miasmatic treatment. Thank you very much for your attention.
Thank you, Dr. Rita. Indeed, a really very well presented case and emphasizing the need for miasmatic evaluation. Many a times we just give a symptomatic treatment and we feel that the patient would recover, but he doesn't. And we really need to look into this miasmatic evaluation for a proper cure of the patient.
Thank you very much. Thanks.
Yes. And now I would ask the chairperson, Dr. Anu, if she has any question for Dr. Reena.
No questions. It was very nice to see the great transformation from malnutrition to a chubby child. That's really great.
Really.
It's good.
Yeah, thank you very much. Thank you. I'm glad to.
Good case.
Yeah, thanks.
Thank you, Dr. Irina, Dr. Anu. Now, going on further, I invite my co-host, moderator, Dr. Nirmal Yadav Pangte, to take over from here. Dr.
Yeah,
Visible. Yes, ma'am, it's visible. You can just start the presentation, the slide presentation.
fine. Thank you very much. And good day to all and all the best wishes from India, Baroda. I'm going to talk today on exploring the scope of multidisciplinary approach in the management of cerebral palsy with mild, moderate, and severe disability, with mild, moderate, and severe intellectual disability in the age group below 18 years, and that's a pilot study. The plan of the presentation is going to be that we will talk about the background and then importance of multidisciplinary approach and understanding pilot project on cerebral palsy, and then we will also discuss about the result which we have been able to achieve. If we start with understanding the background of the problem, we can understand that if you consider global population, then it is 10% can suffer from disability, wherein in India, 3.8% of population suffers from disability. And 15 to 20% from cerebral palsy. So you can consider 3 per 1,000 live births are suffering from cerebral palsy. So what is cerebral palsy? A group of disorder of the development of movement and posture causing activity limitation attributed to non-progressive disturbance occurred in the developing fetal infant brain. Now, most important aspect in this is the comorbidity, which is normally ID, behavioral issue, epilepsy, recurrent URTI, and that management makes it very difficult and it has an impact direct on the development and management of the case. Now, when we talk about CP, cerebral palsy, the goal is not to cure, of course, not to make them normal. Goal is to increase the functionality, improve capabilities, cognitive development, social interaction, independence. And all these things would require multidisciplinary approach. The change in the quality of life is a major concern which needs special attention. So that is how we could start, and we established Ummid Cerebral Palsy Center in 2016, wherein all the facilities are available under one roof, and the most importantly, all the cases are given homeopathic medicine. So we are catering to 80 children suffering from CP at our center, and our tagline is hope lives here, because these are all hopeless disorder. So pilot project was carried out at Ummid Center in 2018-19. So this is the place. I would just, since it's a global colloquium, I would like to mention that we are from India, Gujarat, and then Vadodara district, from where Karjan we are working at. So this is my sample collection center. So what are the objectives that I'm going to talk about? So major objective are three. One is to understand what is the change effect we could bring on in the GMFM score, right? So gross motor functioning score, that how much measure score, how much we can produce result. Effect through IQ, DQ and SQ also. And we also wanted to focus on creating a effective posology through the tool, which is remedy response evaluation form. Study design is non-randomized, non-controlled with sample size of 50. So this is the methodology that we work here, that each case is identified, then pediatric neurologist and pediatrician would examine, and there will be rehabilitation therapy in the form of physio, opt-in, speech and all, but the major therapeutic aspect is homeopathic medicine. If I talk about this study, the enrollment and continuity, if I say, the enrolled cases were 80%, wherein treatment continued for one whole year were 56%. And most importantly, all 56% continued homeopathic medicine, wherein 36 went for infrequent therapies and 20% with regular therapies. Demographic characteristic, you can see the age group, male-female ratio, where male is more affected than female, and most importantly, causes for cerebral palsies, which are normally prenatal, perinatal, and postnatal. Here we could find that maximum causes were from perinatal. Classification of disease that were observed was topographical. There are 4 things you can classify: topographical and physiological. Topographical were 65% suffering from quadriplegic, 10 diplegic and 25 hemiplegic, wherein spastic were 63. So maximum were spastic quadriplegic CP. With GMFM score, we had all the score, but maximum patients were with the GMFM 3 and 4 score with moderate and severe ID. Comorbidity, which is the important thing which I would like to focus here, was with cerebral palsy, malnutrition 35, epilepsy 29%, and recurrent URTI was there with 17%. Overall susceptibility management and assessment and posology, if I talk about, majority of the cases had moderate susceptibility and sensitivity. So the posology which was identified was low to moderate potency with frequent repetition of indicated remedy. Now, if I go to results, what we could identify that after giving those medicine, what are the results we could find out? So majorly we could see that in comorbidity, we could identify that malnutrition was better with 20%, wherein epilepsy was better with 80%. It is very important to manage epilepsy because single attack of convulsion can bring on the regression and the development goes down. 100% we could see after our homeopathic medicine improvement in recurrent URTI. Scope of homeopathy was very visible through the improvement in comorbidities. Malnutrition, we found it difficult, and when we studied, we could identify that there is a lot of difficulty in deglutition, and that is how difficulties can be there. What are the common remedies which came across? So these are the remedy in which we could identify that calcarea group, especially calcarea cap, calcarea phos, and phosphorus came out maximum in the cases. Now, as I told you, each case is assessed by all the team member. It's an integrated approach, wherein one case is assessed by one and all every 4 months. And these are the assessment of physiotherapist, done by physiotherapist, wherein GMFM score has been assessed. And to our surprise, like we could see the change in GMFM score also. In these are the round that I have done is 8.33. We could find change in GMFM 1 grade 2, and we could get maximum result in grade 3 and 4, which is rather more difficult. And even fifth grade, which is almost immobile, we could see 6.66% improvement in that. So we could see that homeopathic medicine, along with interdisciplinary approach, could definitely had an impact on GMFM score too. And same way it had an impact on IQ, SQ, and DQ. We could see 5% improvement, average 5% in IQ, wherein 2% in DQ, and 2% in SQ and DQ both. So this also talks about that there were cases which slided from moderate to mild MR. So conclusion, if I come to, so homeopathic medicines along with multidisciplinary approach helps to improve GMFM score grade, especially I would say 3rd, 4th, and 5th, wherein you do not expect much improvement, and it does modify IQ, DQ, and SQ. Most importantly, quadriplegic CP, like physiotherapy said, we can't do anything, but we said, let us do something. And we could see that with homeopathic treatment and therapy, we could make changes in quadriplegic cerebral palsy children also. Assessment of sensitivity and susceptibility, the posology that we wanted to identify was moderate to low. So low potency to moderate with frequent repetition, all the cases were given. Of course, it was respective assessment of sensitivity and susceptibility was done. Most importantly, I would say homeopathic medicine definitely helps in comorbidities such as epilepsy, malnutrition, and recurrent URTI, because one attack and everything just slides back. I would like to share physiotherapists and psychotherapists from my team who shared their experience that physiotherapy with homeopathic medicine, patient improves faster. Psychotherapy said non-cooperative or excessive impulsive child becomes cool, calm, and cooperative for therapy after homeopathic treatment. And finally, the most common depicting remedy that we could come across was calcarea group, calcarea phos, calcarea cap, and phosphorus. So looking to this experience wherein we are working in rural where there is no facilities available, we could create this center, Ummid Cerebral Palsy Center, with the support of Lipoid Foundation Germany. And now, recently in October 2020, This was a pilot study, and we have launched a cerebral palsy research project, and we have registered with CTRI. So we are going ahead with the 100 sample size, working better further for this cause. So thank you very much. I would say donors, my international donor, patients, students, team Ummeed, because without whom I cannot do anything, Institute, and most importantly, LMHI Global Colloquium for organizing such a wonderful event. And I cannot forget Dr. Jawahar Shah for always helping for the sake of homeopathy. Thank you very much.
Thank you so much, ma'am. It was a wonderful presentation, and it was an enlightening experience to see that the comorbidities had such a wonderful impact from the treatment, along with the main complaint. Thank you very much. Now, I would like to request Dr. Anu Kapoor. Ma'am, please go ahead and ask some questions if you would like.
Yeah, thank you, Dr. Hema. It was a really practical approach which you have adopted, and you have been very honest in giving your case presentation. I appreciate that. And I think this interdisciplinary approach is very essential to tackle all such cases, and intensive case taking and intent observation is the hallmark of your study. Go ahead. Great.
Thank you so much, ma'am. And I would like to share just 1 minute that this all started with the one case which came with CP, and our pediatrician said, we can't do anything, let them send home. And we said, can we try? And that's how we started working. And now we have reached 280, and we want to reach globally.
Yes,
that each patient of cerebral palsy should get these facilities. And we have really created state-of-art center at Srimati Malini Kishore Sanghvi Homeopathic Medical College and Hospital at Karjan. And I welcome you all to visit our center.
Okay, that's
Thank you.
Good work. Very good.
Namaskar, greetings to all. I'm honored to be here. Today I'm going to talk about our study, Homeopathic Treatment of Adult Acne, an open single-arm non-comparative study. 3 years back, in early 2018, I had this patient, a 38-year-old female. She came for consultation. She was hiding one half of her face with veil. I asked her what her complaints were. She said, "Doctor, it is embarrassing. I have come for consultation of acne. I'm having 16-year-old daughter, and it is her age to have acne, and I am having these. Because of this, I can't go out anywhere." This led us to took her case in detail, and this was the germ for this study. Observational study was done for assessment of effectiveness of homeopathic remedies in treatment of adult acne in typical clinical setting. Acne is a common dermatological condition typically associated with adolescent population. Adult acne is defined as presence of acne beyond the age of 25 years, and it can be divided into persistent acne, which represents a continuation of acne from adolescence into adult life, and these are responsible for 80% of cases, while late or onset acne are significant acne occurring sometimes for the first time after the age of 25 years, which are responsible for 20% of cases. So an observational study was performed on 35 enrolled patients for treatment of adult acne over a period of 12 months from July 2018 to June 2019 using acne-specific quality of life questionnaire and global acne grading system scores. And acne quality of life and GAGS scores were analyzed at baseline and post-medication after 6 months of treatment. Our primary objective with the study was to evaluate the effectiveness of homeopathic treatment in cases of adult acne in typical clinical setting, and other objectives were to assess the impact of adult acne on quality of life and to identify frequently prescribed homeopathic drugs with their effective indications. It was simply an attempt to systematically maintain data of outcomes of treatment, and written informed consent from each patient was obtained. Both male and female patients over the age of 25 years presenting with acne in OPD were enrolled, and each case was recorded on a pre-designed case-taking pro forma. A detailed history and examination was carried out for each patient. Feature of possible hyperandrogenism as characterized by hirsutism, alopecia, or menstrual disturbances were noted. After case taking and examination, patient symptoms were analyzed and each patient was prescribed single homeopathic medicine at a time after individualization. Patients were given only homeopathic medicine with assurance from the treating physician, but no specific counseling or psychotherapy sessions were instituted. No external or local applications were advised. The follow-up period was of 6 months. Our primary outcome was change in GAGS score, and secondary outcomes was changes in acne specific quality of life score from baseline to 6 months after homeopathic treatment. So a little bit about global acne grading system score. The clinical severity of acne was assessed by using GAGS score, which calculates global score by adding the individual scores of 6 locations. This system divides face, chest, back into 6 areas and assigns an area factor of 1, 2, or 3. Each type of lesion is given a value from 0 to 4. Area score is the product of most severe lesion in that area multiplied by the area factor. And the area scores were added to give the total GAGS score. The score of 1 to 18 is considered mild, 9 to 30 is moderate, 31 to 38 is severe, and more than 39 is very severe. And to make it just simpler, if a patient presents with a papule on right cheek, and papule is the most severe lesion in that area, then the area score for right cheek would be 2 multiplied by 2. 2 is the area factor of papule, and 2 is the value of the lesion of papule, and 2 is the area factor of cheek. 2 multiplied by 2, 4. So 4 is the area score for right cheek. Similarly, we calculate area score for left cheek, forehead, nose, chin, chest, and upper back, and we add all these area scores to get a global acne grading score. Adult acne can be associated with substantial impairment of health-related quality of life. The psychological impact of acne is generally significant and largely underestimated in this age group. So a well-validated acne quality of life questionnaire was used for psychological assessment. The questionnaire contains 19 items relating to self-perception, social, emotional, and acne symptoms as perceived by the participant on 7-point scale, with higher scores indicating a better quality of life. The acne quality of life questionnaire contains questions organized into 4 domains: self-perception, role social, role emotional, and acne symptoms. So 35 patients were enrolled, and 32 of them were female and 3 were male. The follow-up period was of 6 months, and among 35 patients enrolled in the study, 32 completed the 6 months follow-up. 3 patients did not complete the study period but were included under intention to treat analysis. Statistical analysis was done using SPSS 19. Quantitative variables were described using percentages, means, and standard deviations. Paired sample t-test and correlation analysis were performed as applicable. A two-tailed probability value of 0.05 or less was considered as statistically significant. Missing values were addressed using last observation carried forward technique. So what we found was majority of patients who presented with adult acne were females. 91% of patients enrolled during this time period were females, and only 3 were males. And mean age of patient was 31.96, that is around 32 years, and 74% of patients were between 25 and 35 years, and 23 were between 36 and 45 years, and one patient was over 45 years. Most of the patients reported persistent acne, while only 6 patients reported late onset acne, and all of these were females. There was no difference in clinical features between persistent acne and late onset acne. The type of lesions were also assessed. Predominantly inflammatory lesions were there in 97% of patients. Scarring. Scarring was very commonly found in patients of adult acne. All men, all 3 men enrolled in the study had scarring, and while 75% of female patients also reported having scarring. In our study, features suggestive of hyperandrogenism, such as hirsutism, were observed in 2 patients, while alopecia was there in 1. PCOS symptoms was there in 2 patients. 10 patients reported using cosmetics in form of facial creams more than twice per week, and 7 females reported aggravation of acne through cosmetics. Family history revealed that 40% patients had at least one first degree family relative with post-adolescent acne. 8 women, that is 25% of enrolled females, reported a premenstrual flare of acne, and seasonal aggravation in acne was noted, summer being the most common, followed by rainy and winter season. Bovista, sepia, alumina, calcarea, sulf, graphitis, lachesis, pulsatilla, sulfur, tarantula were the most frequently used remedies. And there was some change of remedies during the study. 3 patients who were prescribed Rustox in the beginning were required a change to Bovista after 2 and 3 months respectively. And sulfur was changed to Soranum in 1 patient. And tuberculinum was changed to sepia in 1 and calcarea carb in another. And these patients required change of medicine at various points because either they remained status quo of their symptoms or presented with different symptom picture. The acne was mild or moderate in severity with mean GAGS at baseline of 17.51. And predominantly facial acne was present, and there was statistically significant mean difference in GAGS score at baseline and after 6 months of homeopathic treatment. Declining GAGS score indicated decrease in acne severity. And mean acne specific quality of life scores at baseline were 58.06, which increased to 74.60. In this scale, higher score indicating a better quality of life. And p-value here is less than 0.001. Further analysis of 4 domains of acne quality of life, which represent 4 different aspects of health-related quality of life, showed marked improvement. P is 0.000. Interestingly, the perception of patient about their symptoms as reflected in domain 4, that is acne symptoms, also improved, which corroborates with the objective findings of decrease in global acne grading system score. Here in this chart, we can see lachesis. Lachesis was found most effective with mean difference of 31, most effective in improving acne specific quality of life of patients, and other medicines which were very effective were sepia, bovista, and alumina. These are the set of symptoms derived from individual cases, and I will discuss only few highlighting points only because of time constraint. Bovista was prescribed to maximum number of patients, and 4 out of 7 patients of Bovista had this bloatedness or sense of swelling, or they complained about some kind of enlargement of body surface. And because of this, finger usually dented by the instrument with which patients were working. 5 patients of Bovista had aggravation from cosmetics. And another interesting finding was pruritus ani. Pruritus ani was found in 2 patients as a concomitant with adult acne. And there was another interesting finding was pruritus vulva with adult acne was found in tarantula, and patient responded beautifully. So pruritus ani along with adult acne, Bovista patient responded to Bovista, and pruritus vulva with adult acne, patient responded with tarantula. And sepia patient, 3 patients of sepia had cracked lower lip with sensitive hair roots. And this interesting finding was there. Patient was so quiet, so quiet. She used to sit quietly and without answering anything. And even when questioned, she only used to say yes or no, even to the questions relating to how, why, and when. So, as I said, Lachesis show maximum benefit in acne specific quality of life. So this patient, the peculiar feature was amelioration during menses. As we have seen, there was premenstrual flare in most of the cases of acne, but this Lachesis patient has this peculiar feature of relief of acne during menses. And both of these patients were late onset acne, and acne were very sensitive to touch. And I said about tarantula, the pruritus vulva was a very interesting finding along with adult acne. It was present in 2 patients, and acne was pretty late, around menopause. One more thing I would like to add here about rust stocks. The patient had acne on chin with red papular eruptions and itchy acne, which were irritating, and few urticarial patches here and there. And on the basis of this syndrome, we prescribed rust stocks. And surprising, lesions didn't respond even after many weeks. And cases were re-evaluated, and Bovista was prescribed. And these 3 patients responded wonderfully to Bovista. And when we look back in the literature, we found that Dr. Clark and many stalwarts has written, Bovista has cured when rust seems indicated.
Dr. Rashmi, please, I would request you to wind up in a minute, ma'am. Okay, please, we're just running.
Okay, but failed.
Yeah, sure.
Yeah, so I'm summing up the differences between adult acne and adolescent acne. The first is the age. Adult acne are found after the age of 25 years, while adolescent acne are present at puberty and adolescence. And adult acne are more prominent, predominantly found in women, and facial lesions are more common, while in adolescent acne, facial and truncal lesions both are seen. And impact on quality of life is more on with adult acne as compared to adolescent acne. So, and to summarize, so adult acne are commoner in female, impact on quality of life is greater. Stress, cosmetic, family history, acneiform drugs, and hormonal fluctuations were the main causes found. And acne improved. When acne improved, quality of life is also improved. And acne from cosmetics showed much effectiveness with Bovista. And Lachesis was found most effective in improving acne-specific quality of life. And when rust stock seems indicated in beginning, the cases failed. Cases responded beautifully with Bovista. Thank you.
Thank you so much, ma'am. This was such a learning experience to see you show the particulars of the remedies and their action in particular. Thank you very much. Now I'll request Dr. Anu Kapoor, ma'am, to please take the dice and ask the questions if she wants to ask any questions.
Yeah, Dr. Rashmi, very good job.
Thank you, ma'am.
Were you assessing and targeting the etiology also while you were seeing your cases and treating them?
Yes, ma'am. When we were taking the case, so we were definitely asking, and in the pre-designed case taking pro forma, we have many questions related to etiology, whether how the acne started, and as I mentioned, there were 5 main causes which we could correlate. One is stress, another is acneiform drugs, family history, and in some cases we could not get any cause, but these 4-5 causes were there in most of the cases.
And were you suggesting auxiliary methods, diet, etc. to your patient?
Ma'am, no dietary restrictions were suggested, only with one exception. In patients who were prescribed Bovista, we asked them to avoid coffee. So coffee was restricted only in cases where Bovista was prescribed.
No,
Otherwise, there was no.
Otherwise, nothing related
there
to the diet as regards to the adult acne?
No restrictions regarding diet, and no external applications were recommended and suggested.
Okay, great job. Good.
Thank you, ma'am.
Thank you, Dr. Nirbal.
Thank you so much. Thank you, Dr. Rashmi.
Thank you, Nirmal.
And now I'll invite the next speaker in line, Professor Yogesh from Latur, India, to share his observational study on the scope of homeopathy in management of a rare genetic dermatological disorder, acrogyria. I welcome you, sir. The stage is all yours.
Thank you, ma'am. With due respect to one and all, as my topic has been introduced, I will not waste my time in that scope of homeopathy in the management of a rare genetic dermatological disorder, a retrospective observational case study on acrogyria. The objectives of this current presentation is to demonstrate the demands on the part of physician for case taking and case processing, with special reference to document evaluation, building up totality, repertorization, mathematical differentiation, and selecting the simillimum. To learn how to identify and define the potential of homeopathy in a rare dermatological condition having a recurring tendency. These are the two objectives that we are having. The case was brought by a father on 19th of May 2020, and the information was provided like this. A 3-year-old boy presented with the complaints of thin, exfoliated and fragile skin, having premature aging since birth. Slight touch leads to injury, exfoliation, bleeding, and slow healing of the lesion that takes 45 to 60 days to become normal. Frequency of these complaints were 4 to 5 times in a year, and the allopathic treatment consisting of local application was required during this episode, which was painful. The child used to scream, cry, and after 2 to 3 hours, he used to settle to normal. The condition was diagnosed by a dermatologist as acrogyria. This was the image that I had seen at that time. The patient had premature aging, fragile skin was there, right hand, fragile exfoliation, bleeding was there, clots were there, edema. And we can see the, means it is too painful to even observe that condition. The prescription is in front of us. This was the prescription, allopathic prescription given by the dermatologist, and the case was referred by the pediatrician, where the patient's father had taken opinion from the concerned pediatrician, and pediatrician being a friend and patient, he referred this case to homeopathic management. Now, what are the demands on the part of physician, which are propounded in Organon of Medicine 1 to 6th aphorism and 83 that we are going to see? So I was sensitized towards the boy and his suffering. I had no idea about this disease, and again, we have to define the scope of homeopathy in such conditions. Due to lockdown, patient was seen in the waiting room. I took photographs and entered into my cabin, read acrogyria, and case definition was done. This was an attempt to upgrade knowledge of physician. Let's see what is acrogyria. Extremely rare genetic syndrome which begins at birth or soon afterwards, characterized by mild, non-progressive form of skin atrophy due to the loss of fatty tissue directly under the skin, that is subcutaneous atrophy. It is both autosomal recessive and autosomal dominant inheritance, having a female predominance, where the main involvement is of distal parts of the extremities that we had seen in the pictures also, where the condition accelerates aging of the skin and other tissues. The child is shy and calm by nature, timid in front of other than family members, follows what parents, doctors instruct him. This was the thing that was more attracted towards me, that he is following all these things even at the tender age. He takes his own care while playing or doing activities of daily living. He behaves like elder than his age, desires for sweets,
profuse perspiration in general, constipation, and thermal state was chilly. And the important observation that I made, that he was comfortable with his suffering and didn't show any sign discomfort through the condition is painful. Now this is the structure that I made, where I tried to correlate each and everything in terms of the available data, factual data, and the interpretations at mind level. We can see that the skin is sensitive, fragile, and the pathology is of autosomal recessive and autosomal dominant inheritance pattern, where inheritance of a non-working gene from parent is there. We can also see the classification of disease in terms of local one-sided, where the physical symptoms are predominating, and the adaptation pattern that is there to ability to withstand pain in painful conditions. He can take his own care while playing in activities of daily living, and the totality that is available is of pathological general, physicals, and few of the interpretive mental generals. So the basis for miasm and the anti-miasmatic remedy we will see in the next slide. The susceptibility considered was low, sensitivity was moderate, and the potency and repetition strategy that we had decided was of low potency and infrequent repetition. Repertorization was done with Murphy repertory, and after that the thermal filter was applied, where lycopodium and silica were the closely coming up remedy. But we can see that the main characteristic symptom, this is a general complaints and symptoms where the painlessness of complaints which are usually painful is not covered by lyco and silica, whereas the old age premature is also not covered by silica. Here we can see, and lyco is not covering the fragile skin. So what I did, I went through different repertories and tried to find out whether these symptoms are covered by the particular repertory or not. So when we go to the complete repertory, we can find that silica is covering and skin fragile is silica and petroleum. These are the only two remedies that are covering. So I used the Ortega miasmatic analysis, and I found that the psora, psychosis, and syphilitic features are there, and predominance of syphilis is seen in the miasmatic totality. And to my surprise, when I read silica from Kent, I found that such are the long-acting, deep-acting remedies. They are capable of going so thoroughly into the vital order that hereditary disturbances can be routed out. So silica 30 single dose was given. This was the follow-up analysis, where we have taken subjective distress plus generals, new symptoms, susceptibility, reaction, sensitivity, the clinical thinking pattern, disease direction, action, and what kind of expectations or reasons for deviations are there. So we will see the first follow-up. Case definition was done on 19/5, and after 12 days, this was the situation. The father sent me the photographs on WhatsApp, and we can see the change that has been occurred only after 2 doses of silica 30. So that boosted my confidence in prescription. So we can see that a retrospective observational study conducted on this rare genetic disorder. Case was assessed as per the narration from patient's father's symptoms, signs, nosological diagnosis, miasmatic understanding, totality of symptoms, susceptibility, sensitivity, and repetition strategy. Cross-repertorization was done, as I had mentioned earlier. Follow-up was noted once in a month. Assessment was done on the basis of objective findings, and the evidences were photographic evidences were recorded. Care and home case guidelines were followed for the effectiveness of practice guidelines. So this causal attribution between homeopathic intervention and the clinical outcome was also seen by use of Monarch inventory, where it scored 8. So the duration of episode, which was 45 to 60 days, was reduced to 28 days. In follow-up on an average, the duration was 28 to 35 days, depending upon regularity in treatment and exciting causes. Assessment by Monarch inventory, that is the improved version of the modified Naranjo criteria for homeopathy, had a score of 8. It clearly shows that there is causal attribution between homeopathic intervention and the clinical outcome. In conclusion, we can find out the retrospective observational study on acrogaria managed with homeopathic medicine Cilicia showed marked improvement in clinical features, reduction in the duration and intensity of disease. Control studies are needed to investigate the effectiveness and efficacy of homeopathic medicines in rare diseases. Before I wind up, I will just show the follow-up that we had. So this was the follow-up that we had conducted, and he is still with me with homeopathic treatment, and we can see the current scenario, that this is the thing that we are having. And he had only, since 1 year, he had only 3 episodes, and all the episodes were managed with homeopathic medicine, and hardly in between intermittently when he had no lesion. At that time, we had managed this case with only Saclac because I didn't want to unnecessarily repeat the medicine, and he was totally prescribed only Saclac intermittently, and whenever the injury was about to start or there were few complaints, again I started the Silica 30 single dose weekly. So this is what I had done. These are the references, and I think an acknowledgement. Thank you very much. If you have any
Thank
questions,
you.
yeah.
Thank you, Professor Yogesh, for this wonderful presentation. Now I request Dr. Anu Kapoor ma'am to please take on the dice and ask any questions.
Well, Dr. Yogesh, I think it was a great challenge taken up by you. The initial picks
Yes,
were
ma'am.
very ferocious, and
Yeah, I was highly sensitized to that.
the story was very interesting, and that is really good. Tackling a genetic case and a complicated case, I really congratulate you on this.
Thank you, ma'am.
Very good.
Thank you, ma'am. Another challenge was to complete in time.
Yeah. Good.
Thank you, ma'am.
Thank you so much, Professor Yogesh and Dr. Anu Kapoor ma'am. Now I'll request our last speaker of the session, Dr. Amrit Kalsi, who is working as a Chief Medical Officer in Directorate of Ayush, New Delhi, to present her case series on usefulness of homeopathic medicines in treating patients suffering from alopecia areata. I welcome you, ma'am. The stage is all yours.
Can you hear me, please?
Yes, ma'am, you're audible.
Okay. Can you see my screen? Is my screen visible?
Yes, I can see that your screen sharing has started, but
Is my screen visible?
Yes, ma'am, it's visible. You can start now.
Is the slideshow on?
We can see the slides, but not the present. Yes, now it's on.
No, it's on. Okay.
Yes.
Greetings to all from Delhi, India. Present study has been presented as an e-poster as well with the abstract ID 150. Alopecia areata is one of the common dermatological problems characterized by initial lesion of circumscribed, totally bald, smooth patches. Homeopathic literature is rich in therapeutics for alopecia, yet the problem a practitioner faces is in using a standardized approach in management of the cases. The study presented addressed the above issues and proposed 3 strategies with the aim of understanding the scope of homeopathic medicines in alopecia areata. As you already know, alopecia is of 2 types, psychiatrical and non-psychiatrical types. Alopecia areata falls under the localized non-psychiatrical alopecia. The aim of the study was to ascertain the usefulness of homeopathic medicines in treating patients suffering from alopecia areata. The study was conducted in the outpatient department at Delhi Government Health Center, Sector 19, Dwarka Amrai, New Delhi, for a period of 1 year in India. Detailed case taking was done for each of the 37 cases with clinically diagnosed alopecia areata, and the appropriate medicine was selected for each individual patient as per the proposed 3 strategies, as we told in the next slide. Repertorization was done by synthesis repertory, radar, or materia medica, or both. The strategies explained are strategy 1, constitutional, where besides alopecia, there were many important symptoms available at mental or physical plane of the patient. Strategy 2, one-sided disease. Only main complaint of loss of hair in circular patches can form the basis of prescribing, but all such cases needed re-evaluation for further changes in prescription through status mobile. And strategy 3, a strong predisposing factor such as trauma, emotional stress, allopathic medication. Such cases required thorough analysis, and evaluation of totality of symptoms, as explained in the Principles of Management of Chronic Diseases. Assessment of the disease vis-a-vis outcome assessment was done on the basis of 4-point scale, grade 1 to 4, developed by McDonald and Norris, and standardized photographic assessment scale, PAS 1 to 6, Isabella. A comparative grading used by Kwok was also used to assess the severity of the disease. Grading of the disease, simple classification had been devised, which described scalp and body hair separately. Severity of the disease was defined as by Kwok in mild, moderate, and severe and ophiacic patches. The outcome assessment was used, the scale was used was McDonald and Norris, and the endpoint of therapy was hair growth Grade 1, 2, 3, 4, as you can see, vellus hair, sparse pigmented, non-pigmented, terminal hair with patchy alopecia, and grade 4, terminal hair all over the head. Photographic assessment scale was used in our study because the earlier stages only subjective scales were used. So this was hence validated the importance method of chronological photography using a standardized approach of numerical scale by Isabella. As you can see, the photographic assessment scale showing excellent improvement showed the hair regrowth of 81 to 100%, and photographic assessment scale 5 showed very good improvement with 51 to 80%. There's a general management, observations and results. Majority of the cases, 70.2% cases belong to the age group of 16 to 45 years. Scalp was a common site of involvement, 81%, and only few cases, the patches were on areas other than the scalp, face beard 16.2% and mustache 2.7%. 83.7% sought treatment within 6 months. The problem of alopecia areata does seem to be of significant cosmetic importance, as more than 75% reported within 6 months. This table shows that family history of alopecia areata was noted in 13.5% patients in the study, which is in agreement with the study run by Thomas and Cardian, where they found 15.5% cases, and Muller and Winkelmann noted 18% cases. In contrast, study by Manzoor and Masood found family history of alopecia areata to be as low as 1.5%. In the present study, family history of autoimmune diseases, psoriasis, SLE, thyroid, diabetes was noted in 12 patients and atopy in 5.4%. Of the systemic diseases observed with alopecia areata, as shown in the figure at the bottom, atopy showed the highest frequency, and among the 8 cases noted to have atopy, seasonal rhinitis and asthma were common. In the present study, 6 patients had chronic and recurrent type of disease. Other systemic disorders noted in the studies were anemia, diabetes, epilepsy, PCOD, varicose veins, and tuberculosis. This slide shows the associated cutaneous diseases and nail involvement in patients with alopecia areata. The severity of disease was classified according to QOC, and 24 patients had a mild disease, less than 3 patches, less than 3 centimeters. 11 patients had moderate disease, greater than 3 patches and more than 3 centimeters diameter. An ophiacic pattern of alopecia was observed in 2 patients. The present study did not come across any case of severe form of disease, alopecia totalis and alopecia universalis, indicating that patients suffering from severe disease perhaps preferred or resorted to other form of treatments. The assessment of the cases was done on a 4-point scale. And as you can see in grade 1A, 28 cases, 2A, 1B, 6, and in grade 2B, 2 patients were there. This slide shows the response to the treatment. Figure indicates that 16 cases, the 43.2% showed constitutional symptoms and hence were prescribed according to strategy 1. The percentage of cases that fell in strategy 2 was 29.7% and 27% cases fell in strategy 3. Further, the results of treatment were encouraging, with significant proportion of cases in all strategies showing improvements on photographic assessment scale 5 and photographic assessment scale 6. This is the comparative response shown in strategy 1, 2, and 3. More than 80% improvement, that is photographic assessment scale, has been observed in 56.3 cases under strategy 1, 27.3 cases under strategy 2, and 40% cases in strategy 3, indicating that pattern of using constitutional medicines as the first line of treatment in prescription is a better option. Overall, 43.2% cases showed success rate on photographic assessment scale 6. Improvement from 51 to 80%, that is very good improvement, photographic assessment scale 5, have been observed in 3 cases or 18.8% in strategy 1 and 1 case each in strategy 2 and strategy 3. A total of 13.5% cases showed very good improvement on photographic assessment scale 5. Looking at the percentage in no improvement, photographic assessment scale 2, it can be inferred that there are highest number of failures in strategy 3, followed by failures in strategy 2, and with least failure in strategy 1. In this study, no case got worse in condition photographic assessment scale 1, and no adverse events were encountered, which makes the therapeutic ratio high. In the study, 12 different types of constitutional medicines were administered to 16 patients with alopecia areata that were treated as per strategy 1. The indicated medicines which were found useful and showed improvement on photographic assessment scale 6 are Natrimur, Calcarea carb, Epismel, Argentum nitricum, Phosphorus, Sepia, followed by improvement on photographic assessment scale 5 by Medurinum and Floric acid. Although as per strategy 2, following medicines were chosen for prescription, but results could be seen with Floric acid, selenium, and Barita carb on photographic assessment scale 6. It is worth mentioning here that there was a case which first presented to be in strategy 2 due to altered picture presented by the patient with paucity of symptoms and therefore categorized under one-sided diseases. Selenium was given up to 200 potency, which was a partially indicated medicines, and no improvement was happening. After 2 months, while excessive symptoms came up to create a new picture, so detailed case was retaken according to a clearer picture with the appearance of new totality of symptoms with mental and physical generals. This made the case to be then categorized into strategy 1. Floric acid 200 was selected as the next indicated medicine, which was given up to 10 and showed good results with photographic assessment 5 improvement. This observation was in line with aphorisms 179 and 180 of the Organon. Under strategy 3, the improvement on photographic assessment scale 6 was attained by acid phos, cantharis, sorinum, and tuberculinum, followed by improvement on photographic assessment scale 5 by mancinella. Thus, the results of the study corroborated with the homeopathic literature. Now, this slide shows the assessment of various potencies and corresponding responses to constitutional drugs in strategy 1 and other drugs corresponding to strategy 2 and strategy 3 in patients suffering from alopecia areata. These are the 3 cases which are presented in the e-poster and showing a good improvement on photographic assessment scale 5 to 6 under strategy 1, 2, and 3. In conclusions, homeopathy has a very good scope in treating alopecia areata. Findings of this work suggested 3 kinds of approaches to handle the case as per the 3 strategies for treatment of patients suffering from alopecia areata with a recommendation of constitutional approach having a better outcome. A long-term treatment with meticulous follow-up is also required. Recommendations: further, the study to be conducted on a larger set of patients and placebo-controlled settings are important to establish efficacy of homeopathic medicines. Services of a psychosocial counselor can be utilized in assisting the patients to overcome the stress and inferiority complex for better treatment outcomes. Now, this was the abstract which is available in the e-poster section. And I thank Dr. Manchanda and LMHI and Dr. Nayak for all the opportunity. And this is the photographic section of cases and 37 cases which were recorded. Thank you for your patient listening, and thank you, LMHI.
Thank you so much.
And I rest my presentation.
Thank you for the wonderful presentation, ma'am.
Thank you.
I'll invite Dr. Anu Kapoor to now take on the dais and please ask any questions, ma'am, if you have any.
Well, Dr. Amrit, it was a very
Yes,
well
ma'am.
presented case.
Thank you, ma'am.
A lot of hard work has been put in, as it is showing. That's good. Are you still in touch with these patients?
Ma'am, I was there in Dwarka long time back.
Okay.
And that's the reason I could not follow up. And some of the patients, yes, they were, because one patient was the one is given in the e-poster. She was, when 6 months old, she had completely alopecia totalis in the head. And she came to me and it was an opportunity to take record of the case. And she presented with the grade 2B. In the sense, she had alopecia in the scalp and the body also. And she was followed. And in fact, when I was in Jawalapuri now, she came up to me all the way after the recurrence, and it was recurred only after 7 years.
Okay. That's good. That's really good. Great.
Thank you so much, ma'am.
Thank you so much for these enlightening case presentations. And indeed, chronic skin complaints have a very detrimental effect on the confidence of a person and the quality of their life. So with these remarks, let us conclude the session, and I'll invite over my co-host.
Yes, thank you, Dr. Nirmal. And I think we've come to the end of such a wonderful, enlightening session. And we've discussed the most relevant topics of this era, I guess, the acne and the alopecia and the pediatric disorders, the conditions. I think I want to add one thing that these pediatric conditions, I think the another bigger challenge in treating them is the diagnosis. I think most of the parents are unaware. They feel that the child is just hyperactive, so they don't even take them to the doctor. So one thing is we have to increase the awareness amongst the parents also, so that we get to diagnose the case early and start the treatment earlier. And we've been treating such cases beautifully with homeopathy all over the world. But I think these such observational studies are very important so that we can establish the system and we can have a very prominent evidence-based decision making. And now I would request our chairperson, Dr. Anu, to give her concluding remarks for the session, or if she has any questions for any of the speakers, ma'am.
No, I think I've been through the journey with all and I've been questioning them. But overall, I congratulate all the presenters for their excellent work. And they have really done very well. They have put in a lot of hard efforts. And I believe that this particular field, children diseases, skin diseases, we have a lot of scope and we can do a lot more. So keep the show going, keep the hard work, and all the best to all of you. I congratulate Dr. Nirmal and Dr. Shali for their wonderful experience, share for their wonderful comparing. So,
Thank you so
thank
much, ma'am. Thank you.
Thank you, ma'am.
Thank you so much, Dr. Anu. And I would also take this opportunity to thank our coordinators, Dr. Radhika and Dr. Ritika, who've done a wonderful job backhand, and Mr. Hime and his team. And once again, I thank you, ma'am, Dr. Anu Kapoor, and all the presenters. Thank you so much. Let us
And
conclude this
Thank you,
session.
madam. Thank you.
before we conclude, may I request everybody to please switch on your cameras. We'll have a group picture
Yes.
for this. Yeah. If everybody can be stable, and here we go. 3, 2. All right. Thank you. I'll take this opportunity to thank, first of all our speakers, all the attendees who were there on the virtual dais. It was a great pleasure having you here. I would also like to thank our coordinators who had put in the tremendous work. I would also like to thank our moderators to moderate the session seamlessly. And of course, I would also like to thank our chairperson. Thank you so much. And I'm Himay Lakhani. I'll be signing off this session with a namaste and thank you for being on the virtual platform. We will be online again back tomorrow. The time is going to be 530 hours CET on 11th of December. Till then, good night, everybody, and take care. Have a good day. Thank you.
Thank you. Thank you very much.
Thank you so much.
Thank you.
Good
Thank you and good night to all.
Thank you, everybody.
Thanks a
Thank
lot.
you.
Thank you, everyone.
Good night. Thank you.
Good night.